I don't know why I'm skipping.
Good afternoon, everyone. My name's Anthea and I'm the Assistant Secretary of the Mental Health Access Branch in the Department of Health and Ageing. Welcome this afternoon to the launch of version 4.0 of the National Mental Health Service Planning Framework and the framework's new website, online training and planning support tool. Firstly, I would like to acknowledge the Ngunnawal people who are the traditional custodians of this land on which I am presenting today, and to pay my respect to elders of the Ngunnawal Nation, both past and present. I extend this respect to the traditional owners of the lands upon which all attendees are gathered and all Aboriginal and Torres Strait Islander people attending today. The material we are launching is the result of collaboration, shared visions, and also a lot of hard work. And I would like to begin by thanking the Australian Institute of Health and Welfare and also the University of Queensland for the immense effort they have invested into the development of the new planning framework material and also for facilitating today's launch. I extend my thanks to members of the Framework Steering Committee, also primary health networks, local hospital networks, users and experts for their tireless work shaping this important resource. Next slide, please. Okay. Following this welcome and introduction, Sandra from the University of Queensland will provide an overview of UQ's research and development work. Then Cecilia from the Australian Institute of Health and Welfare will provide an update on version 4 of the framework's planning support tool, and Jenny from the Australian Institute of Health and Welfare will showcase the framework's new website. Finally, Kate from the University of Queensland will provide information on the new online training program, and we will finish with a question and answer session. So firstly, some history of the planning framework. Next slide, please. In 2011, the Commonwealth and all states and territories provided funding to establish the framework as a commitment under the 4th National Mental Health and Suicide Prevention Plan. Version 1 was rolled out to jurisdictions during 2014 and 2015. In 2016, the Department of Health funded the University of Queensland to refine the framework, examining issues and implementing priority fixes and enhancements. This work resulted in version 2, which was released to jurisdictions and PHNs from 2017. Again in 2017, continuing the development of the framework was endorsed under the 5th National Mental Health and Suicide Prevention Plan. And in 2018, the Department of Health and states and territories funded the University of Queensland to further develop and refine aspects of the framework. This presentation highlights the changes the University of Queensland and the Australian Institute of Health and Welfare have made to the framework following this activity. Next slide, please. The framework provides a comprehensive model of the mental health services required to meet population needs and is designed to help plan, coordinate and resource mental health services. It includes a detailed taxonomy and definitions of service types accompanied by national average staffing profiles and salaries. The associated planning support tool allows users to estimate need and expected demand for mental health care and the level and mix of mental health services required for a given population. The framework builds on state and territory expertise in population-based mental health service planning and collates expert input from around 250 service managers and planners, public and private sector clinicians, community sector professionals, consumers, carers, technical experts, and academics. Next slide, please. The framework provides a strong foundation for integrated regional planning across the primary health, specialised mental health and non-government sectors through its modelling of the full spectrum of needs, consistent taxonomy and definitions of required service types. It offers a nationally consistent language to describe mental health services in a region and how these services can work together to provide care along the treatment continuum. At the local level, the framework provides a benchmark against which available service capacity can be compared to identify priorities for planning and service development. Regional planning for services is essential to ensuring all people can access the mental health supports they need when they need them. Next slide, please. The release of the new material marks a new era for the framework. Early next year, the framework will be handed to the Australian Institute of Health and Welfare for ongoing management. I don't expect that this handover will impact the way that users access and use the framework, given the Australian Institute of Health and Welfare's involvement in this initiative to date. They will continue to be the primary contact for queries relating to the framework's development. We will work with the Australian Institute of Health and Welfare to ensure the management, maintenance and development of the framework continues to meet stakeholder needs. We are also working to establish new governance arrangements to guide the future of the framework following the dissolution of the Council of Australian Governments last year. We will reach out to relevant stakeholders once arrangements have been finalised. The new framework material comes as we finalise the National Mental Health Workforce Strategy. This strategy will consider the quality, supply, distribution and structure of the mental health workforce and identify practical approaches governments can take to implement, to attract, train and retain the workforce required to meet demand. This includes ensuring decision makers, policy makers, planners and experts are drawing on the best available evidence to understand demand for mental health services. Modelling and data sources such as the framework will be fundamental to the strategy's implementation to ensure everyone can access the mental health services they need. Finally, I would like to reiterate my thanks to everyone involved in the framework's development over the last 10 years and for their ongoing and valuable contribution. I look forward to working with you all to continue refining the framework to ensure it accurately represents mental health service demand now and into the future. I'd now like to hand over to Jason.
Hello, everyone. My name is Jason Thompson and I head the Mental Health Analytics Reporting Service Unit at the Australian Institute of Health and Welfare. Today's webinar will provide an update on the latest developments on the National Mental Health Service Planning Framework project, including completed research and development work, the new planning support tool, the new website and online training courses. You can post questions in the chat box and these will be answered at the end of all presentations. And I'll just make a note that this is presentation is being recorded to make it available as a resource for people that can't attend today. Our first speaker today is Sandra Diminic from University of Queensland, who's the lead for the project at the University of Queensland, and she'll be talking about the research and development work that has been undertaken over the past 3 years to enhance the service planning framework. Sandra, please.
Thank you very much, Jason. So I'm going to talk through some of the research and enhancements that we've been making to the service planning framework model over the past few years that have been released as part of version 4, which is the new version that will be available to users. Next slide, please. So I'd just like to start by acknowledging the traditional owners of the lands on which we're meeting today, which for me in Brisbane is the Yagara and Turrbal people, and pay my respects to the elders past and present and emerging. Next slide, please. So I won't spend too much time on this because Anthea has given a great introduction to the framework overall. I'm aware that we have a mixed audience of people who would be very familiar with the framework and perhaps some people who are hoping to get more involved with it. But it is designed to be a needs-based planning tool, building up from the population level of mental health need to estimate the various kinds of services and resources that we need in the mental health system to meet those needs, and to support that at a regional level to inform planning and provide a sort of consistent language and a consistent set of resource requirements for people to work with. Next slide, please. So this is what the model looks like broadly for those who aren't so familiar. There's a number of input components that are required in terms of bringing in data to inform the epidemiology or the number of people who need different types of services. There's a taxonomy or menu of all the service functions or service units that are required in a comprehensive mental health system, a series of defined workforce types across mental health providers, peer workers, clinicians, vocational mental health workers, and so on. The likely funder that's required to deliver a service based on how that works at the moment in the system. And those elements are brought together into care profiles, which outline the types and quantities of different types of care required for groups, multiplied through with some parameters around how services and workforce operate in the system to produce estimates around resources like the workforce full-time equivalents that are required, the number of mental health beds, occasions of service, and consumers who require different types of things. Next slide, please. So for each age group, and there's a number of age groups across the framework, there is a bit of a breakdown for a particular population, a snapshot over 12 months of what populations and how many are required, might need different types of services, and those are broken down into these subgroups across severity levels. And next slide, please. Then associated with each of those need groups, there's a care profile which has lines to break down different types of services, and those are used to quantify the resources. Next slide, please. So as you can see, there's a fair bit of data that sits in the back end of the service planning framework model. So an important part of this framework is the idea that that data and the clinical improvements and what we think best practice is does need to be refined and updated over time as we have new advances in what a good service looks like and what service responses are effective, and as we learn more about the epidemiology in the population over time as well. So the process of having an initial framework, but also the need to kind of update and enhance that. And in the process, as Anthea mentioned, of rolling this out to users a few years back, people did identify a number of priority areas to look at enhancing and improving the framework's utility for users. Next slide, please. So my team at Queensland Centre for Mental Health Research at the University of Queensland was funded in 2018 to further develop the model and also build some enhancements particularly for Indigenous and rural populations that weren't specified clearly in the model previously, as well as some general updates across things like the epidemiology. And I'm just going to walk through at a very high level some of the key changes that have been made. There is a lot more information available, which I can't cover in this timeframe, but in the documentation as well, it will be available. Next slide, please. So overall, we've followed the same methods that have been used in developing the framework to date. So we convened a number of expert panels with expertise around Indigenous mental health services, rural mental health services, young adult mental health services, and epidemiology and forensic populations. Those service expert panels include people delivering services like service managers, planners and clinicians, people working in the community sector, lived experience from consumers and carers, and other people like academics and technical experts in a particular area. And alongside consulting with experts and workshopping, what good practice looks like and what other resources are available to support that, there's been analysis of available data around service needs and service utilisation across published academic studies, across the National Mental Health Survey data that we have, health services administrative data like of beds and that sort of thing, as well as looking at best practice around things like clinical treatment guidelines and exemplar service models that are operating in Australia that look like the model is effective and something to be emulated. Next slide, please. So we've applied that method working through over a number of years on a number of different areas. So the first one is looking at enhancing the model for the specific mental health needs of Aboriginal and Torres Strait Islander populations in Australia. And really we wanted to look at the higher levels of mental health need that we know exist for these populations, but also culturally appropriate models of care as well. So after the consultation and analysis that's been done, what's been applied in the model is a multiplier for the prevalence of mental health needs across different levels of severity and age groups. And that's based on a number of data sources around higher levels of psychological distress and around higher utilisation of specialist services as well. So those multipliers have increased the prevalence for Indigenous populations as a national average, and that ranges from 1.5 to 3.9 times higher, depending on the age group and the severity level. There's also new workforce types specified for Indigenous specified workforce, Indigenous clinicians, Indigenous mental health workers and Indigenous peer workers, which have been then applied in a number of the care profiles and teams. And there are specific Indigenous services, so there's holistic primary care teams designed to be delivered in an Aboriginal health service type environment that have been modelled in some of the care profiles, and funding to engage with cultural consultants, so traditional healers or elders to support culturally appropriate care as well. There's also been modelling across the spectrum of the care profiles to allow for the need to engage in culturally appropriate treatment, and also to respond to higher service needs and the needs to engage with a range of other support services. So that's more frequent and longer mental health assessments for these populations, increased time for care coordination and liaison with other services or agencies, and increased time to engage with and support families and carers as well. The last major change that's been made for this is to bring forward the age for the care profiles related to supporting people with behavioural and psychological symptoms of dementia or PTSD, as we know that the prevalence of dementia actually occurs earlier in Indigenous populations. Next slide, please. So the second major area of improvements is around, again, enhancing modelling specifically for rural populations. And this has primarily been focused on looking at alternative models to deliver equitable and the same levels of care for people with the same levels of need, but in a way that acknowledges some issues around workforce capacity and access in rural areas. So as this was a first run at trying to implement something for rural populations in the framework, this is essentially a binary model where we've got now an urban population and a rural population that's been modelled for, which has been cut using the modified Monash model. And for the rural population, at a national level, on average, the prevalence of mental illness is actually pretty similar for both populations, but we do know that access issues cause some issues in terms of higher levels of distress and suicide and so on. So one of the principles that's been developed based on consultation with experts is to use a hub and spoke approach. So this has been implemented, but it's really more of a suggestion. The resourcing is the resourcing, but the framework also has a flag to say that some of these resources might be something that you could deliver in a hub. The hub being a larger regional area that then supports some smaller rural or regional towns associated with that area. So the hub could provide some more specialised services that aren't able to be provided in all the regional areas. And then the spokes have also local services as well. So what's been implemented for the rural model is a number of changes to the service models for rural areas. So we've got rural specific community teams and inpatient units, which have a smaller size and perhaps not operating at the same level of efficiency as an urban area, more supervision time, greater overhead costs associated with travel and those sorts of things as well. More time for consultation liaison to hospitals and that sort of thing, and centralised support in the hub with specialist consultation to support those rural workers as well. There's additional local workforce support to help people access telehealth and e-therapy services rather than relying on them to try and do that themselves, and additional resources around things like patient transport, additional overhead costs that are required to run these rural services, and additional flexible funding for psychosocial support services in these areas as well. And some enhancements to the local supports for people who might live in a rural area. So a little bit more time around care coordination and liaison, and increasing again engagement and supports with family and carers. Next slide, please. So the way that the models have been scoped is we now have an additive model. So the original service plan grant model we're calling a base model, which has primarily been scoped around urban non-Indigenous populations. So for Indigenous populations living in urban areas, they would get the base model plus the Indigenous enhancements. And for rural populations who are non-Indigenous, they would get the base model plus the rural enhancements. And where we've got Indigenous peoples living in rural areas, then both types of enhancements actually get applied, so that there's issues around cultural sensitivity, but there's also issues around remote access and living in a rural area as well. Next slide, please. So in addition to those enhancements, there was a strong desire from users to have more specific modelling around youth populations, particularly the spectrum of the sort of 12 to 24 or 15 to 24 that we think about in the youth space. So we've created a new age group for 18 to 24-year-olds, which has been carved out of the original 18 to 64-year-old adult age group. And this age cutoff, there's different cutoffs for different services around the country, but it's been, I guess, a pragmatic choice to line up with existing data and allow some flexibility about the way that people use that age group. So we've developed, again, in consultation with experts, all the new epidemiology specific to this age group and the care profiles, which have been built by taking the adolescent and the adult care profiles as the starting point, but then adapting and enhancing those specifically for this young adult group. And there's some new youth-focused service models incorporated as well, such as youth development supports and youth-specific bed-based services and teams. So the advantage of having an 18 to 24 cutoff is a little bit more flexibility about how people use that. So this can be combined with the adolescent age group to allow people to plan for a 12 to 24-year-old group, or if people need an 18 plus or an 18 to 64 traditional adult population, it can be combined with those older age groups as well. And otherwise, all the modelling follows the same sort of standard in terms of epidemiology and care profiles that we see in the other age groups. Next slide, please. So we've also done a comprehensive update of the epidemiology that feeds into the framework, 2 levels. So at the overarching level of prevalence or mental health needs, including people with sub-threshold mental health needs, we've gone and updated the data feeding into this because the older framework data was actually relying on some of the national surveys that were done in the late 90s, and we have had a number of recent surveys since then. So we've used the Global Burden of Disease Australian prevalence estimates for adult populations, and that's because they actually combine the data from our National Survey of Mental Health and Wellbeing, our Survey of Psychosis, some smaller surveys around things like eating disorders, and do some modelling to smooth out those curves so that they make sense internally consistent across all disorders and all age groups as well. We've also incorporated data from Young Minds Matter, specifically for the child and adolescent age groups, and the longitudinal study of Australia's children for infant populations. And we've used data across the Young Minds Matter and the National Survey of Mental Health and Wellbeing to look at our populations who may not have a formal diagnosis, but have expressed perceived need for care or are using services and might have a need either because they have a past diagnosis or because they have symptoms. So once we had that new epidemiology, we've supplemented that with looking at populations who might have been excluded from household surveys because perhaps they're homeless or they're living in aged care facilities or they have a cognitive impairment, and we've added in a small additional prevalence for those groups. And then all of these disorders and populations have been brought together and adjusted for comorbidity across different diagnoses to give us the final estimates and the severity splits for the populations. So we've also set that up in a way that it's hopefully a bit more straightforward to update that epidemiology going forward as well. And then going from that level to splitting down to some specific care profile need groups, we've also updated the assumptions and the data feeding into those where it's relevant, like what's the need for early psychosis services, or what's the need for inpatient beds, for example. And the level of need for different types of bed-based services has been updated based on newer utilisation data, which the AIHW was able to provide. Next slide, please. So we've made a number of other changes across the model. One of the bigger ones that people will notice who've been using the model previously is that we've streamlined some of the care profiles across all the age groups. So this was partly to consolidate similar groups that essentially had a largely same care profile with slightly different variations of bed-based services or things. And that's really about making the model easier to understand and easier to access, but also easier to update going forward as well, so that we can hopefully have more regular clinical updates in there. It improved the consistency across the age groups, so we had a number of principles that had come into the more recent Indigenous, rural and youth modelling that looked like they could then be applied to some other age groups as well. And where appropriate, we've added some additional top-ups around things like monitoring of antipsychotic medications to sort of streamline that across the age groups as well. We also standardised the care profile naming conventions with the codes. So that was designed to make it easier for people to find the care profiles and the right ones with the right age group in the planning support tool, and also a bit of a standardised format for ease of understanding. So you'll see in the little table here that we've included the age group, an indicator of mental illness or BPSD, and the level of severity for each of the care profiles. And there's a little bit of a cheat table in the release notes that people will be able to see if they're not familiar with the new conventions in terms of how that maps to the old ones as well. We also got some updated data on annual readmission rates from the jurisdictions, and we've updated those in the framework. So the implication of that is after consideration of literature and discussions, we did decide not to make a downward adjustment to readmission because there was a fairly large assumption built into the framework that if we improve community services, there'll definitely be less people wanting to access beds. And because there is a level of unmet need in the community, and because there's so much pressure on beds at the moment, that wasn't actually really an assumption that was backed up by a lot of evidence at the moment. So we've gone back to modelling based on current utilisation for that at the moment. And so we've brought in those current utilisation readmission rates into the model, which has increased the level of bed need as well. Finally, we've just done some updating to scale up those workforce costs for 2021. And the private sector workforce costs have been updated based on the recent available data as well. Next slide, please. So overall, there are some changes in terms of the outputs that come out of the new modelling, primarily driven by those key changes that we've made. So because we've incorporated additional supports and additional care for rural populations, Indigenous and young adults, that has increased the resourcing in terms of workforce and beds and things required for those populations. The increased prevalence and service demand has actually come out of the epidemiology update, particularly at the mild to moderate end. We've seen a little bit of an increase based on the best available recent data that we had. So that will flow through obviously to the care profiles around those groups as well. And we have seen increased bed estimates, particularly for acute mental health beds. And that is based on our updating of utilisation data from more recent data, and also the change to the readmission rates as well. Next slide, please. So there's lots of further development that could be done beyond this, but we've addressed some of the big changes that people were requesting. I think it's important to note that we haven't made any adjustments for the impacts of COVID, and that would be something that would be nice to do, and it may be a short-term impact or a long-term impact, but that isn't currently built into this version of the model. As part of the work that we've done over the past few years, we did have some resourcing to work with some people in the forensic mental health sector to look at whether we could do a national model, what that might look like, to start to develop the epidemiology and the service elements. The team here is currently progressing, developing the care profiles for that population, and we're hoping to be able to continue to finish off that work over the next year or so. And there's a number of other areas that we could potentially look at for further development. So we're very keen to hear from users. We will be circulating a bit of a survey to people to get a sense of what the priority areas might be, if there are particular areas that would make this more usable or more helpful for regional planning. And also feedback is very welcome if you are using the new version. If you notice anything in the modelling that you think looks odd or that might be improved, please do send that feedback either through the AIHW or to the UQ team as well. Next slide, please. And there's much more information about the new modelling available. So on the new website, there's a new documentation package in the public-facing side of the website, technical appendices with lots of details about the epidemiology and the Indigenous and rural modelling there, if people would like to read that. And for licensed users, there's also release notes explaining how things have changed from the previous model as well, which is similar to what I've just covered today. Next slide, please. And that's it. Thank you.
Thanks, Sandra. Next presenter is Cecilia Xu from the Institute, and she'll now talk about version 4 of the Service Planning Framework tool, which will be available to all licensed users shortly. Cecilia, thank you.
Thank you, Jason. Good afternoon, everyone. Get my slides up. Good afternoon, everyone. As Jason introduced, my name is Cecilia Xu. I'm part of the AIHW development team at the AIHW. I wish to acknowledge the traditional custodians of the land we are meeting on, the Ngunnawal people. I wish to acknowledge and respect their continuing culture and the contribution they make to life of this city and this region. I would also like to acknowledge and welcome other Aboriginal and Torres Strait Island people who may be attending today's event. So in my presentation today, I would like to give you a brief introduction of the new planning support tool, the key features of the new release compared to the last version, and then an overview of the new PST and what it looks like in Tableau. So what is the planning support tool? The PST is a tool that used to calculate and report resource estimates using the MH SPF model that Sandra talked about in the last presentation. Registered users can access the PST through an online platform called Tableau. There are 11 standard reports in the newer PST. Some reports are made up of 2 sub-reports. The PST produces a series of resource estimates, such as the number of the workforce FTEs, the staff costs, hours of client demand, numbers of beds and care profile, etc. And what are the key features of the new release? So compared to the last version, the new PST has new reports and filters being added. For example, Report 0 is a new report that allows users to see all the population estimates that are used in the PST. And then some reports have been consolidated. For example, Report 4 beds in this new release include information contained from Report 4 beds and Report 14 beds numbers, FTEs and costs from the previous version. And for all these changes, users will be able to find them in a comparison table provided in the release notes. The next feature is updated population estimates. The populations that are used in the PST are modelled by the AIHW based on ABS population estimates and projections. Users can make population selections by states or territories, SA3, LGA, PHN or LHN. And the last feature I'm going to mention is that each report page now first opens to the Notes tab, which provides an overview of the content of the report and key considerations when using as interpreting the estimates. So how to access the PST? We have the AIH SPF website, which Jenny is going to introduce and talk about in the next presentation. And there are information there helping people on how to register and access to the training under the PST online. In general, the new users will need to fill in a form to register for interest and establish contacts with the project team. And if the organisation you work for were eligible, then we will send you relevant documents such as confidentiality agreement to fill in. You will also need to complete a compulsory training. And once all the requirements were met, we will send your individual username and the login and the link to the PST, which you can just click and have a secure login. Existing users, you can access the new PST using the same link as the previous version. And if users would like to access the previous version, there is instruction video on how to navigate between different versions on our new website. So this is basically what's the screen, the login page look like. And once you log in, this is a home page, basically a content catalog, and you can click on any of the named buttons here to go directly to the report you want to look. And the second tab is the release notes, which we strongly encourage users to have a read first before diving into using the PST. On this page, you can find the most important information about the new release, including the modelling changes, tips on how to use the filters, and additional information which assist you using and interpreting the estimates. On the next page, you can find additional resources that you may need to help you using the PST, including information about the population data, the AIH SPF website, and the Tableau website. And the next 4 pages are where users can interact with the PST and make selections only of your interest. So for example, on this page, you can choose which population you're interested in to have the estimates being reported on and for which year. As mentioned earlier, the populations are available by states or territories, PHN, LHN, LGA, SA3 separately, as well as crossways such as PHN by SA3 or PHN by LGA. The projections are ranging from financial years 2015 to 16 to 2035 to 36. The next couple of pages are where you have the option to change the staff prices modelled in the PST. So users can select whether you want to put inflation into the calculation, at what rate, and from which year. In the new release, we have updated the default salary modelled in the PST to be 2021 Australian average salary. You can also change this default salary that modelled in the PST to fit for your scenario. As you can see here, there are two settings for staff salaries. One is team-based and one is private. In this new release, we've added additional staff categories and types to reflect the changes in the model. And once you change the numbers or made the selections on the filters, the changes will spontaneously apply to the estimates in all the reports. Now we'll move on to the actual report. Each report page has two tabs, the Notes tab and the Table tab. The Notes tab provides an overview of the contents of the report and the key considerations when using and interpreting the estimates. And this is what the Table tab looks like. Please note that we've blacked out the estimates, as not everyone here today are licensed users. So, and then on the right side, there are filters that you can use specifically just for this particular report. At the end of these 11 reports, there are basic customer reports templates that allow users to modify and build their own report to meet their needs. And there are instructions in the user guide and also videos on the website, which will help users on how to modify and build their own customer reports. So that's the end of my show and tell of the new PST. I hope you're excited and looking forward to using it. And I would like to acknowledge and thank all our stakeholders, especially the users who participated in our user testing and also those who provided feedback from the testing. Thank you very much for your input and suggestions. I will come back to answer any questions you may have. Meanwhile, if you need to contact us for further information, this is our email address, mmhspf.aihw@aihw.gov.au. Thank you. Back to you, Jason.
Thanks, Cecilia. Our next speaker is Jenny Brew, who actually leads the Service Planning Framework team at the AIHW, and she's going to tell us about the new website. Thank you, Jenny.
Hello, everybody. Excuse me. As Jason mentioned, I'm Dr. Jenny Brew and I lead the Service Planning Framework team here at the Institute. I am just going to hopefully show you the new website. You see my screen? Okay, just technical issues here. So some of you may remember the previous website, so the content will be familiar, but it's all been updated to reflect the changes to the modelling that has occurred over the past few years and that Sandra was talking about earlier. First, I'm going to show you where it is. It'll be a good start. So there was a link on one of Sandra's slides, but if you just go to the AIHW website or just do www.aihw.gov.au/NMHSPF, and there it is. As of Monday, there will be another way to navigate to it. It just hasn't quite been implemented yet. But basically, if you go to the AIHW homepage and scroll down here, there is some featured sites and there's lots of other interesting work that the Institute is doing, but there will be a box here for the Service Planning Framework website. So I don't need to show you all how to use the website because I'm sure you've all used one before, but I just want to point out a couple of different things on here. So across the top are the menus, and if you click on them, there will be menu bars down the side. Some of the, sorry, excuse me, there are some new content. So there are lots of videos that have been produced by the University of Queensland QCMHR team, and they are really good. So I encourage you to have a look at those ones as well. The public documentation package that Sandra was talking about is all here as well. You can see there's a mix of PDFs and an Excel file. I will point out, so the training program, again, if you've registered for access in the that we sent out earlier, you should have got an email today about your training access. But if you have people in your team or people that you know, or you yourself are not yet registered, just come to the website. There's a request access button. You just fill in this and we'll get back to you about whether your organisation is licensed, and we can sign you up for the training program. So anyone who got an email with a confidentiality agreement today, so that was for the training program, and once we've received those, we can load you in. Then Kate will talk to you a little bit more about the training program after this presentation. Okay, the other feature of this site is that it has a secure or an area that's just for licensed users or registered, or those registered for training. So in order to access that, I'm just going to quickly show you it. It is, everyone should have hopefully received emails this morning about access to the secure area. And if you haven't, please contact us. But down the bottom of the page here, there's a login button, and it will have some of the terms and conditions of agreeing to access the website. And then you simply click sign in. And just for a little bit of confusion, the email address that you will use will be your first name, your last name, and it'll be at users.aihw.gov.au. As mentioned, all these instructions will be in your email if you're a registered user or you've signed up for training. But I just want to make sure that it's very clear. So obviously your password. So one of the differences with the website is that now it requires multi-factor authentication. So once you put your password in, you will just need to approve it. Excuse me while I approve it. And it'll take you to this landing page. So the Service Planning Framework website is one of the first websites that the Institute has produced that has this secure area. We expect there'll be more coming online in the next few months. And so if you happen to have access to any of those, they will show up here. So excuse me. Oh, excuse me, sorry. So you just click on this, the Service Planning Framework site. And you can see that it looks like it did before, but there are menus here that have a padlock against them. Oh my goodness, excuse me, I'm sorry. So these are the sites that are available only to licensed users, and you will not be able to see them unless you're logged in. So some of the things to note about this as well. So there are links to our Tableau planning support tool. And we recognise that it's a little bit confusing to have different logins. So your website login will be different to your Tableau login, but we are working on that, and hopefully in 2022 we will align those two, and so that there will be only one login. But for the moment there is two. And there's also a link out to the training site. So I've had a question in the chat about will people need to redo the training? And the short answer is no, you don't. But if you'd like to know a little bit more detail about the changes here in the licensed user section, there's an excellent video which summarises the changes for the rural and Indigenous modelling. that you might like to watch before you look at the new version. And I think that's about it. There is additional support material here. So again, it clearly states which ones are publicly available. And these are the same as the ones on the, if you go up here and look through them in here. But there are additional documents that are not available publicly. They include the user guide to the PST and some of the other documentations about the modelling parameters. There are a bunch of videos available as well. So one of the things Cecilia talked about was a video about how to look at previous versions of the PST. So for example, you might want to compare the previous estimates with the new modelling just to see what it looks like, and they will be available here. There might just be some technical issues with these, but we are working towards a fix and they should be ready to go by next week if there are any that don't work. So this is a live website, obviously we're looking to improve it. So please give us your feedback. If you have anything at all, our email address again is nmhspf.aihw@aihw.gov.au, and we will work on making improvements as we can. And lastly, I'd just like to say a big thank you to our AIHW web and communications team who have gone above and beyond to ensure the website has been delivered in really short timeframes. So big thank you to them. And now I will hand back to you, Jason.
Thanks, Jenny. Our next presenter is Kate Gossip from the University of Queensland, who'll be talking about the new online training course that the team has developed. Thank you, Kate.
Thanks for that introduction. Yes, I'm Kate. I'm from the Queensland Centre for Mental Health Research, and today I'm going to be talking to you about our very exciting new online training program. So just wait for the slides to pop up. So yep, I've done my introduction. Next slide, please, Kayla. I would also just like to acknowledge the traditional owners of the lands upon which we are all meeting from today, from across Australia. Please. As you've seen from the presentations today, the framework is a really useful tool. It's got a lot of great information and data that can help you with your service planning work, but it can also be really complex to use. So in 2017, the Australian Government Department of Health funded our team to design and deliver a face-to-face training program. We trained over 200 individuals to understand, apply and interpret the framework and the planning support tool correctly. Hopefully a lot of you are online today and really excited about these new developments. But we did receive some feedback that the face-to-face training was really great, but it did have some limitations. Next slide, please. Related to the face-to-face nature of the training program. So it was a big time commitment to travel to a capital city where a workshop was being held, and also to attend 2 to 3 non-consecutive days to complete the training. There was also obviously costs involved to travel to the workshops if you weren't located in one of these capital cities, and that you could only complete the training at certain times when the workshops were being held. Please. So some feedback we received was that it would be really great if we had a more easily accessible training program that users could complete in their own time that was convenient to them, but they still wanted to retain the practical elements and the interactive exercises that we did during the face-to-face training. And they also still really wanted to have opportunities for lots of discussions with fellow participants and also the training facilitators. Please. new solution, which is really exciting. So at the start of this year, the Australian Government Department of Health and each state and territory health department funded our team to design this online training program. It can be accessed at any time, anywhere, and is self-paced, so you can complete it at times convenient to you. Next slide, please. Online training course replicates the content that we delivered in the face-to-face training. It's organised into 4 sequential stages. So in stage 1, you will be introduced to the framework model components and understand what these are and how they all fit together. In stage 2, you will learn about how to use the planning support tool and to correctly interpret the outputs. In stage 3, you will learn about how to use or to compare existing on-the-ground services data to the outputs produced by the tool to help identify potential planning priorities. And in stage 4, we do have a formal assessment where each person going through the training will be required to go through a mental health service planning scenario, so answering a series of questions that will really demonstrate to us that you understand the content, you can use the tool and correctly interpret and apply the outputs. Slide, please. Online training course is really to ensure that participants achieve the same learning outcomes as people who undertook the face-to-face training. So to do that, we've tried to make it as engaging and interactive as possible. Next slide, please. So as Jenny's already mentioned, we do have a lot of videos. So there are a series of informational videos that describe the components of the framework model. We also have instructional videos that demonstrate how you can use Tableau. Next slide, please. And this is sort of a bit of a screenshot of some of the training content. So as you'll see, there's some text-based content that you can read through. There's also a lot of activities, so drag and drop activities, fill in the blanks just to sort of reinforce the learning that you've done in each section. And then at the end of each section, there is a little checkpoint quiz. So these are just multiple choice questions that you do need to answer and achieve 100% on in order to progress to the next section of the course. Next slide, please. The course, we have embedded a short evaluation. So there's just 10 questions. And we'd really appreciate it if you could take the time to answer these. This is the first time we're delivering the training in this online environment. So we're really keen to hear what you liked, what you really, really liked, maybe what you didn't like, and areas you think that we could improve. Next slide, please. And once you've completed the training, you will become a licensed user of the framework. You'll have full access to all the framework documentation and the planning support tool, and that can all be accessed through that area of the website that Jenny just showed us. You will be able to access support from the framework team, so the AIHW team, and also our team at the Queensland Centre for Mental Health Research. The training course will remain available to you once you finish, so you can dip back in at any time to refresh your knowledge or watch the videos again. And you will remain a licensed user while you are employed by your licensed organisation. So any individual that's working in a mental health service planning related role within a licensed organisation is eligible for the training. As Jenny mentioned, there is a request form on the AIHW's website, so just jump on there and register your interest if you haven't already. Next slide, please. And just some important dates. So trainees must request access for the first run of the training as soon as possible. So we know a lot of you have already registered, which is really great. But ideally, if you are wanting to do so, please register this year. The training course actually opened today, and you'll have until mid-March to complete this first run of the training. Next slide. And that's all from me. So yeah, if you have any questions about the training, pop it in the chat and we can answer those shortly. Back to you, Jason.
Thanks, Kate, and thanks again to all the presenters. very useful update on all the developments in the National Service Planning Framework project. And now we've had a small amount of time to answer questions from the audience, and I believe we've received some already. I think, Sandra, you have a couple sitting with you. Can I hand to you?
Thank you, Jason. Yes, I've got a number of questions that came through on the modelling while I was presenting, so I might run through those. So first of all, what area sizes or definition has been used for grouping rural communities that help inform the access to service question? I apologise if I misinterpret any of these questions because they came through on specific slides, but I've only seen them after I finished talking. So in terms of defining rural in the service planning framework, the modified Monash model has been used to group areas into urban based on being at modified Monash level 1 or 2, or a kind of one holistic group for rural, which runs from modified Monash 3 to 7. Now, obviously, the modelling may not be perfect for very remote areas because there's a wide variation across the country, but that has then run through to the population estimates that sit behind the tool. So for the each of those catchments, for what proportion sits in modified Monash urban versus rural areas based on the framework definition, that then runs through to the resource estimates that are produced. So for a particular PHN, for example, you might have some of your population who are rural and some who are urban, and those estimates are combined for the total population of your catchment, or you can view them separately for different populations. So in terms of area sizes around the hub and spoke model, that hasn't really been specified. What happens when you open up the tool? Say you're planning for a particular PHN area, for example, you can see all the estimates for your area, you can look at just the estimates for your rural populations, and then within those rural populations, you can actually turn on a filter that says, and for the resources for this rural population, based on the people living in that area, X amount of this resourcing might be located in a hub. And where that hub would be a decision that the planners would make as part of implementation processes. I'm not sure if there's anything else in that question that I've missed, so apologies if I have, but I might move on to the next one. So why not use multiplicative loading for Aboriginal and rural patients? So that is certainly the starting point that we had for consideration when we started looking at modelling for that. I'm aware that this is a strategy that's used across a number of areas in health. And so first of all, we thought, well, should we just have a resource loading for these populations? Because the framework is built up from this idea that you start with the population who has a need, you identify the different components of services that are involved, and then that generates the resource estimates. I guess building an overlay that's just focused on you need 2 or 3 times more resources for these populations doesn't provide a lot of guidance for how many people have a need or exactly what kinds of services. So we wanted to be able to go the next step and provide a bit more indication of, actually, if you're going to invest with additional resourcing, where does that need to go? Where is the need? Is it about more people who have a need? Is it about the services that are more expensive? Is a different model of service delivery? So that's the way that we're focused on building the rural and Indigenous models. It does work out, meaning that the resourcing is higher for those populations, but it also provides guidance on where that resourcing might actually be placed to meet those needs for those groups as well. All right, next question here is, have the disability weights changed, not just the prevalence? And if so, how material are these to the new outputs? So we haven't used any disability weights in the model. So the Global Burden of Disease does produce burden of disease and disability weights, but we've just taken the prevalence inputs out of that, which is just based on mainly household survey data. And we just use the prevalence to identify levels of need combined with severity and demand rates. We haven't modified the severity splits that were in the model previously. We did do some work to explore that as an option, but we need to spend some more time on that to get it to a state where it would be able to be implemented in the model. It's not straightforward to do that from a data-driven approach. So the severity splits across, particular disorders have been brought forward from the previous version of the model, but they've been applied to updated prevalence for those particular disorders. Okay, the next question is, why does the 16 to 17 years old population not included in the youth category? And that's a very good question. And as I said, we've taken a bit of a pragmatic approach with trying to define where the boundaries were for our youth age group. So we did do a bit of a consultation, have a look at the different way that services operate. It seemed that in the primary care space, for example, we have a lot of services like Headspace, which target a broader to the 12 to 25 years population. And then we have some more specialist services, particularly when we look at things like inpatient services that tend to start around the sort of 16 to 21, 16 to 24, 15 to 21 kind of population. Because there's some inconsistency and everybody operates those services a little bit differently, there wasn't one clearly distinct age group that we could pick. The reason we've ended up choosing 18 to 24 and 12 to 17 is it just seemed to be the most flexible approach to cover a range of different scenarios. What that means is there are going to be some 16 to 17-year-olds who might need admission, small numbers into perhaps broader youth beds, and the actual service modelling that's in the taxonomy for the framework does include some teams and beds that might actually cover the spectrum of young people, with probably an emphasis more on the 16 to 24, but it doesn't mean that potentially a 15-year-old might not be suitable in some circumstances for that service. So we've really just taken a pragmatic approach there. Okay, the next question is, what about infant mental health services? So there is obviously some modelling already in the framework around the 0 to 4 age group, and there's also modelling for supporting parents in the perinatal period, and also just general parenting for people with severe mental illness who might need support in that role. We did do some scoping work to discuss with some experts around trying to perhaps improve or update the modelling around both perinatal and infant mental health services. Certainly like to explore that further. What's been brought in there at the moment is updated epidemiology based on estimates from the longitudinal study of Australia's children. And we've done some general updating across the whole model in terms of that consolidation process, which includes updating some of the estimates around level of need for perinatal mental illness as well. But other than that, there's probably some more work that could potentially be done in that space, but we haven't explored it fully. All right, the next question on my list is it correct that I said that there's little evidence on the impact of expanded community services on acute bed-based requirements? So no impact has been modelled from expansion of community mental health services on the acute system. That is correct. There's not really any good benchmarks for us to say what the absolutely appropriate level of acute beds should be. I know that people take approaches of looking at benchmarking against other jurisdictions and things, but ultimately research doesn't tell us exactly what the right number is. So although at an individual level, providing supportive community care can reduce people's individual need for an admission, at a population level, there's little evidence that actually improving the system, community system, reduces the impact on beds. Because what tends to happen is as one person doesn't need an admission, there's actually other unmet demand of the community that then takes advantage of the fact that that bed is available. So while there seems to be a fair bit of pressure on beds and it takes some time to develop community services, and we're not 100% convinced that there won't be other unmet demand in the community that might present for these beds if they're available, we've just modelled based on, I guess, utilisation and status quo around the acute beds, with the idea that that can then be updated and refined as demand or the amount of services available might change over time in the future. All right, next question on my list is, after reviewing the outputs from user testing, the Indigenous specific estimates seem to be lower than expected. So in Queensland, the Indigenous FTE for jurisdictional clinical ambulatory services isn't very much. And a number of the rural HHSs aren't showing any Indigenous FTE requirements at all. So is this linked to the hub and spoke model, or is the Indigenous FTE model to run through, say, community controlled health services? So what we have, I guess, in terms of the specified workforce, we have a number of ways of looking at this. So we've got some Indigenous specific clinicians, mental health workers and peer workers, but we haven't modelled that an Indigenous specified workforce would provide all of the care for Indigenous populations. So if you look just at that, then you would definitely only see a proportion of the care that's required for Indigenous populations. In fact, the bulk of the care is still going to be provided by mainstream clinicians and service providers, and that's primarily due to the lack of workforce capacity, but also consumer choice. If you then select the Indigenous population and just look at the estimates related to that, you should be able to see all the resourcing that belongs to those populations. But again, as we said, it might be different providers. If we're looking at jurisdictional clinical ambulatory services for Indigenous populations, there should be a mix of Indigenous and other team-based care built in there. So if people are looking at that and they're still finding the numbers don't gel for what you think should be happening in your jurisdiction, we're definitely keen to get that feedback, and it's something that could be looked at going forward as well, because we'd like to get that feedback from users. All right, I'm just going to have a quick look down the list and see if anything new has come up. Apologies for being slow on this. I think these are all about training. Hang on, are there any plans to potentially include crisis intervention services as standalone elements within the service planning framework model at some point? Look, that's a good question. I guess there's bits and pieces in the model at the moment. We've got acute care services that run through the states that are sort of in there in terms of providing both a triage service and also intensive care for people in various stages from the state system. There are residential crisis and respite services modelled in the framework as well, but they're primarily a community-based service. So we're definitely keen to get feedback if there are particular areas that need to be enhanced and perhaps a bit more detail on what the model should be as well. Do we have the same restrictions with the small population in the new model, under 100,000 taken with a grain of salt, rather than rigid reliability? Absolutely, I think that applies across the whole model. As we've mentioned, probably the epidemiology and the kinds of service modelling and workforce parameters that have been used are national averages. Although we now have some enhancements looking at Indigenous populations and rural populations, which does improve the reliability. You know, if you are planning for a smaller region, the local context is going to be really important as well. I think that's it for me. So I'd like to hand back over to Jason or somebody else to answer any other questions.
Thanks, Sandra. Kate, can I hand to you to address any of the training related questions, please?
You're on mute, Kate.
Hello? Yeah, so there's been a few questions about the training. One that has come up is about whether existing users will need to complete the training again. So the answer is no. If you've already been through the face-to-face training with us and officially been registered as a licensed user, that is still current. You don't need to do the new training program. However, if you wanted to do a bit of a refresher, you're very welcome to jump in and do the new online training as well. Training questions. So there were a couple of questions about why the training is only available until mid-March. Essentially, that's because that's when our contract is to, but there's definitely discussions and plans being put in place to ensure that the training will be available beyond this date. But just in terms of like a course management perspective, we want to sort of have batches and cohorts going through the training so we can help manage, you know, helping you and answering discussion boards and things like that. So for this first run, it would be really great, yeah, if everyone could get their training done by mid-March. There is also no cost at present, so definitely jump in and yeah, get in and do the training now. There's a question about if there's any provision for PHN and LHN/HHS users to complete the online training together. Not really. So part of the licensing is really tied to you as an individual. So you need to go through the training and demonstrate to us that you, as an individual, have the required competencies and knowledge to be able to use the framework correctly. However, in saying that, there are lots of discussion boards throughout the course, so we really encourage everyone to use those and build a bit of a community of practice going through the training. And yeah, you can also ask us any questions if you need help or support as well. And in terms of staying engaged with users beyond the training program, we have previously had sort of discussion forums on the old website. I don't think we have that feature on the new website. But yeah, if that's something that users are really wanting to be able to, you know, easily stay engaged with other users from their regions or from around the country, then we'd definitely be keen to hear about that. The survey that Sandra mentioned about future priorities for development of the framework, that survey will also include questions around what your support needs are. So yeah, definitely keen to hear your ideas because we know it can be complex to use, especially if it's been a bit of time between use of the tool. So we want to be able to help you as much as we can. I think that's really all the training questions. Jason?
Thanks, Kate. And we do have I believe we have a couple of website related questions. I'll throw to you, please, Jenny.
Jenny, you're muted.
Phew, you didn't hear my coughing fit. Excellent. So one of the questions which I meant to answer when I was going through the website was about comparison of the outputs in version 4 versus previous version. So there's a bit of information in the Tableau or in the release notes, and they're available in the licensed user section of the website. And that'll just outline some of the changes that Sandra talked about. So things like the increase in beds, that information will be in there. But if you have any more specific questions, just send us an email and we'll try and get back to you on that one. Sorry, I'm scrolling through the questions. I don't know if there was many more. It looks like a couple of people have had some issues with the authentication of access to the website. So if you just download the Authenticator app prior to requesting the QR code, that should work for you. So just make sure you have everything ready to go before you do it, and that will work. But if it still doesn't work, please contact the comms team and they will help you through that. And just a couple of questions that have been answered. So if you are licensed in one PHN and you move to another one, then you do not have to train again. Your license stands. So thanks, Kate, for that one. Yes, and today's session is recorded. It will be on the website. We just need to work out where to put it. So we will let everyone know once it is available. And I think that might be all. So Jason, I might throw back to you to wrap up, I think.
Thank you. And look, I'd like to thank all the presenters and for all the participants. We had a great list of questions, so it's good to see people engaged. And so, as said, this will be provided as a resource on our website in the near future. And again, thank you everyone for your participation. Very worthwhile event. Goodbye.